Here is your question.
Okay.
Okay, so if you have read and understood, considering its surgical pathology station, kindly tell me, after reading the stem, what are the differential diagnoses that you'll consider for this patient?
Okay. It could be giant cell arteritis,
Good.
like
And
temporal arteritis, or also could be other type of vasculitis. Also could be hypothyroidism maybe,
okay,
and
what investigations would you do to confirm your diagnosis?
okay, I will go for temporal artery biopsy
Okay,
and also inflammatory marker like EHR,
okay, and
and also biopsies are maybe ultrasound for the vessels. I'll go for CBC and CRBSR and
yes,
also fundoscopy for the eyes.
okay. What's happening? Why is patient complaining of transit loss of vision?
It could be vasculitis of ophthalmic artery,
Okay,
so lead to Ramosis ligatus, like due to ischemia in the optic nerve.
what is the pathogenesis behind the giant cell arteritis?
Okay, it is as the cause idiopathic, but that lead to thinning of the whole of the vessel's wall, intimal thickness, and the media lead to the medial layer of vessels, internal elastic lamina fragmentation, and also CD4 and CD8 lymphocyte infiltration in the media, and all of this lead to thickness and of vessels wall, and that lead to narrowing of the vessels wall, and unfortunately to ischemia, decrease of blood flow and blood clotting.
Okay, excuse me. Right. Can you tell me, you said you'll do the biopsy. How conclusive are the biopsies when they are taken for the confirmation or diagnosis of giant cell arthritis?
Okay, we'll take a multiple biopsy, like a long one, because it is like a skip lesion disease, maybe missed, and I think
In 50% of cases, biopsy is not conclusive, right?
yeah,
It comes out negative. All right. Can you please tell me what is the most, all right, you've already told me, what is the treatment that you can offer to the patient?
okay. When I suspect the disease, I will start hydrocortisone
Okay.
to prevent blindness,
Yes.
and I will give like 100 IV
Yes.
hydrocortisone, or
Patient is an
sorry,
elderly patient with already elderly patient with postmenopausal, and you will be giving steroids. What would you keep in your mind?
okay, I'll keep in my mind osteoporosis risk, so I
Very
will give
good.
the patient gives the patient vitamin D and forget the name. I'll give the patient just 1 second. I forget the name of the drugs.
Okay, we'll
and,
come back to that later.
Yeah, also
Right.
calcium and badmidrinate, I think, or I forget it.
Okay, can you please tell me
Calcium.
what might be the other causes of because you're giving if we are giving steroids, patient can have osteoporosis that can lead to pathological fractures. Can you mention some other causes of multiple pathological fractures?
Okay, pathological fracture, it could be due to osteomyelitis, osteoporosis, osteogenesis imperfecta, Paget's disease, primary bone tumor like multiple myeloma, or
Very good.
metastasis bone tumors.
Okay, osteomalacia or Paget's disease, or okay.
Yeah.
Very good. All right. Can you tell me by which mechanism this corticosteroids, they cause osteoporosis?
Okay, steroid lead to directly inhibit of osteoblast activity in the bone marrow, and also lead to increase or activating of osteoclast activity, and lead to decrease the bone matrix, and also inhibit absorption of the calcium from the gut, and also what osteoporosis of steroid.
Yeah.
Yeah, okay. Separation of the bone marrow.
Stimulation. Okay. Basically, I wanted you to tell me direct inhibition of osteoblast formation, direct stimulation of bone resorption, inhibition of GIT calcium absorption, and stimulation of renal calcium losses, and then leading to inhibition of sex steroids. All right. Can you tell me, in case of joint cell arthritis, which vessels are involved?
Usually external cranial part of extra carotid artery, like medium and large size vessels like temporal artery and lingual artery in this patient, maybe. Also in the internal carotid artery, like ophthalmic artery. And
Okay.
couldn't remember what else.
All right.
Medium and large size vessels.
This patient, you've already given steroid to this patient, and after a while, she presents with, she just wanted to climb off the bus, and she presented with a fracture of thigh. Yeah, a fracture of hip, you can say. What would you do? Like, if you have to operate on this patient, what would you consider, or how would you manage the patient?
I will consider the risk of a dystonia crisis. So I will optimize the dose of steroid, converting from oral to IV.
Very good.
And increase the dose. And also I will consider give the patient 100 at induction and 200 infusion post-op the first days, and in the second days, if the patient can tolerate orally, then can double the dose of the oral dose till the patient can then tapering to the normal dose after a few days. And also I will consider this risk of hematomesis like this. I will give the patient PPI before the operation. And
how long would you consider, or how long would you carry out this procedure, these medications, or this measurement?
Okay, the first day post-op, I'll give the patient like 100 induction and like a bolus, and then give 200.
That depends
After
on
that,
the type of surgery you are performing.
yeah, depends of the type of the
All right.
surgery. And
one last
yeah.
question: who would you involve in the management of this patient?
Okay, endocrinologist and also the surgeon and the endocrinologist, and also orthopedic surgeon and ophthalmologist maybe.
Yes.
No, okay, yeah.
Yes, and ophthalmologist as well, and the local GP of the patient.
Or the
Good.
patient itself.
Good. Very good. Excellent.